Welcome back to the deep dive. Today we're tackling a really fascinating figure, someone whose career journey takes us from the microscopic world of immunology right through to the big picture of national health policy.
That's right. We're looking at the life and work of John Michael Dwyer, an Australian doctor, professor, and, well, a really tireless public health advocate.
Exactly. And this isn't just about listing achievements. What we want to do for you, the listener, is really trace how a top clinical immunologist became this major public voice.
A voice really dedicated to demanding rigor, fighting for evidence-based medicine, and taking on misinformation and, frankly, unproven practices. It's quite a transformation.
It really is. So we'll follow his path, starting with some pretty cutting-edge research, actually, at Yale University.
And then right into the thick of the AIDS crisis in the 80s. That experience seems absolutely central.
Definitely. And then we'll see how that leads him into advocating against health fraud, tackling pseudoscience, even within universities and government policy. It's quite the story arc.
And I think the key question running through it all, the thing we really need to figure out, is how managing a massive public health crisis like HIV/AIDS, how did that shape his conviction?
His conviction that you absolutely need both solid, rigorous evidence and a respect for human rights to build any kind of effective health system.
Precisely. That seems to be the thread connecting everything, doesn't it? From the hospital wards to the halls of parliament, decades later.
Okay, so let's lay the groundwork. Where did this all start? He was born in Melbourne, 1939, but his medical journey kicked off in Sydney.
Yeah, University of Sydney, got his medical degree, the MB.BS, back in 1964. Standard path initially.
But he didn't just stop there, did he? He pushed on pretty quickly towards specialization.
No, definitely driven. By 1968, he'd earned his fellowship of the Royal Australasian College of Physicians, the FRACP.
Which, for listeners, means he's gone through significant extra training, passed tough exams. He's a specialist physician now, operating at a high level already.
Right, but then comes this. Well, this fork in the road. While he was doing his residency work at St. Vincent's Hospital, he landed a scholarship.
From the Australian Asthma Foundation. And this seems to be the moment. Just 1 year of research at the Garvan Institute.
Yeah, it was maybe just meant to supplement his clinical work, but it completely changed his direction. It sort of hooked him.
Hooked him on research.
Exactly. It seems he realized that understanding why the fundamental mechanisms of disease was where he could make the biggest difference, not just treating symptoms.
So that led him away from a purely clinical path.
Pretty much. He moved into academic research, ended up at the Walter and Eliza Hall Institute in Melbourne in '69, really digging into immunology.
And that led to his PhD.
Yep, finished in '72, University of Melbourne. Clinical immunology, and the thesis title. It's quite telling, isn't it?
Cellular interactions with antigens in the immune response. It sounds incredibly fundamental.
It is. He wasn't just looking at treatments. He was down at the cellular level, figuring out how the body's defense system actually works, how it recognizes threats.
And you can see how that deep fundamental knowledge would become his benchmark later on, right?
Absolutely. If you're going to claim something affects the immune system, you'd better have evidence that stacks up against that level of understanding.
Yeah.
It kind of baked in an intolerance for claims without solid data.
That scientific grounding then catapulted him overseas to the U.S.
Yeah, the American phase. A scholarship to Yale. And he didn't just pop over for a year. He stayed for 14 years. A really significant chunk of his career.
And it wasn't just any posting. He got major recognition, didn't he?
Oh, definitely. Support from the Howard Hughes Medical Institute pretty early on in '73. That's a huge deal. And consistent funding from the NIH, the National Institutes of Health.
These are the big players in U.S. medical research funding. They back people they think are going to lead the field.
And he did. Climbed the academic ladder at Yale, became professor of medicine and pediatrics.
And he headed up clinical immunology there for 7 years.
That's right. So by the early '80s, he's established himself as a global authority in his field, based at a top institution, backed by serious funding. And that's right when the world is about to face something completely unprecedented.
Yeah, this is where his academic expertise crashes headfirst into a terrifying reality. His time leading immunology at Yale, it lines up perfectly with the emergence of AIDS.
The early '80s. Just think about it. Total mystery, fear, panic, stigma. And he's right there at the epicenter in the U.S.
He wasn't just observing, he was actively involved from the very beginning, trying to understand this new disease.
And not just treating patients, though he did that too. His research background was crucial. He was digging into the mechanism. How was this virus actually destroying the immune system?
The source material mentions his work on T8 cells specifically.
Right. T cells are like the generals of your immune army. T8 cells, or cytotoxic T cells, are the specialized soldiers that kill infected cells. Understanding how HIV disrupted them was critical to figuring out why the immune system collapsed so catastrophically.
So you really needed an immunologist like him with that deep cellular understanding on the front lines.
You absolutely did. His work provided some of those early vital clues about how the virus worked. But the need wasn't just scientific, was it?
No, the human crisis was escalating, and in 1985, he comes back to Australia.
Bringing all that frontline Yale experience with him, right when Australia was grappling with its own rising fear and uncertainty about AIDS.
And he steps into massive roles, not just one job, but several key leadership positions at once.
It's quite something. Professor of Medicine and head of the medical school at UNSW. Plus, Director of Medicine at the big teaching hospital complex, Prince Henry and Prince of Wales.
So he's leading medical education and overseeing clinical care for a huge part of Sydney.
Yeah, talk about pressure. And inevitably, HIV/AIDS remained his immediate focus back in Australia. He was central in getting the early antiretroviral drugs into use here.
But the job quickly became about more than just medicine, didn't it? The fear, the panic.
Oh, the moral panic was overwhelming. That's why his role on the National Advisory Committee on AIDS and AIDS from '87 was so important and so difficult.
Because they were recommending policies based on public health evidence, but those policies flew in the face of public fear.
Exactly. Things like needle and syringe exchange programs, even in prisons, and arguing against segregating HIV-positive prisoners.
Why were those things so controversial?
Because the public health logic, engage with reality, reduce harm, prevent transmission, clashed with the desire to punish or isolate. Segregating prisoners, for instance, sounds tough, but it drives the problem underground, increases risk. Same with clean needles.
And the government didn't adopt those recommendations at the time.
No. Too politically unpopular. Too much fear, not enough focus on evidence or, frankly, human rights. And this is where Dwyer's core principle really solidified.
Which was?
That effective public health policy cannot be driven by fear or moral judgment. It has to be grounded in evidence and respect the rights of the people affected. Otherwise, you alienate them and you lose control of the epidemic. It just doesn't work.
That principle got tested in a very public, very painful way, didn't it? The Charlene Spiteri case in 1989.
Oh, that's a powerful story. He was advising the NSW health minister, Peter Collins, at the time.
And Spiteri, an HIV-positive sex worker, was forcibly detained by the government.
Yes, despite Dwyer and others arguing strongly against it, it was driven by media frenzy and public pressure. The minister apparently felt he just had to be seen to be being tough.
So politics trumps the medical and ethical advice.
Completely. And the awful irony for Dwyer. He was the senior doctor whose unit was actually forced to hold her in a locked room, against his professional judgment, against his ethical stance.
Turning his medical ward into a temporary prison cell, essentially.
Pretty much. And it blew up nationally, featured on 60 Minutes. Imagine the impact that had on him. It showed him in the starkest possible terms that leadership in health meant fighting political battles, dealing with raw public emotion, not just science.
You can see how that experience would, well, change someone. Harden their resolve, perhaps.
I think it had to be transformative. Being forced to implement a policy you know is wrong and counterproductive. But even amidst all that local turmoil, his commitment to fighting AIDS globally continued.
He founded the AIDS Society of Asia and the Pacific.
Yes, ASAP. And that organization is still going strong, running major international conferences, ICAP, across the region. It shows this incredible capacity to act on multiple fronts, even under intense pressure.
So after decades at the forefront of clinical medicine and research, including that intense period with AIDS, he retires from full-time teaching in 2006, becomes Emeritus Professor at UNSW.
But retirement for him didn't mean, slowing down. It really marked a shift, a pivot.
From academic leader to, what? Full-time advocate.
Pretty much. His focus became much broader, championing evidence-based medicine across the entire system and pushing for major structural reform.
And he had this quote about why he felt compelled to do this.
Yeah, it's very telling. He said, "As a doctor, I know that even the most intelligent of us, faced with a life-threatening situation, may suspend our normal good judgment and be easily exploited."
So he saw a need to protect people not just from disease, but from systemic failures and exploitation.
Exactly. He saw the vulnerability, and he turned his attention squarely onto the structure of Australian primary care. He was deeply critical of it.
What was his main criticism?
Fundamentally, that it was set up to treat sickness after it happened, rather than keeping people well. It lacked the focus, the investment in preventative strategies, especially for chronic lifestyle-related diseases which were just exploding.
And that failure in primary care had knock-on effects.
Massive ones. He talked about his own hospital, Prince of Wales, having to turn ambulances away because the emergency department was constantly choked.
Why? What was filling up the ED?
Often, problems that should have been managed much earlier in the community. Patients who couldn't get a nursing home bed, people who couldn't afford ongoing GP visits. The hospital became the disastrously expensive safety net for a failing primary system.
It sounds like a system under incredible strain. So what was his proposed solution?
He championed this idea called the medical home.
What does that involve?
It's about moving away from the solo GP model towards multidisciplinary teams. Doctors, nurses, allied health professionals, mental health experts, all working together in primary care settings.
And the focus shifts.
Completely. The focus becomes proactive, keeping communities healthy, managing chronic conditions effectively before they become acute crises that land people in hospital. Investing upstream, basically.
It makes logical sense. Preventative care to reduce the burden on expensive acute care.
Exactly. It echoes his AIDS experience too, doesn't it? You need a population-focused, proactive strategy, not just reactive treatment.
But changing a whole system like that requires serious political will.
And that's what he realized was missing. Around 2003, the federal and state governments were locked in negotiations about health funding. But what were they arguing about?
Hospital beds, budgets.
Pretty much just hospitals. They were completely ignoring how hospitals depend on everything else: prevention, primary care, mental health, aged care, indigenous health. It was all siloed.
So he saw a need to force a broader conversation.
Precisely. That's why he founded the Australian Healthcare Reform Alliance, AHCRA, in 2003.
What was the goal of AHCRA?
To create a unified voice, to bring together all the disparate groups who knew the system needed fundamental change but weren't being heard individually, to coordinate their message and put real informed pressure on the politicians.
And who was involved in this alliance? It wasn't just doctors, was it?
No, that was the key. It was broad. The Australian Medical Association, yes, but also the Nursing Federation, Catholic Health Australia, the deans of all the medical schools, specialist colleges, consumer groups. A really powerful coalition.
So they could speak with one very loud voice on the need for reform.
And it worked. Pretty quickly, AHCRA became recognized as a, quote, powerful force. Government had to listen. They were pushing for those fundamental changes to structure and funding, pushing towards that more integrated, preventative medical home model.
Okay, so he's tackled the big structural issues in the mainstream system with AHCRA, but then he turns his attention outwards, towards practices outside conventional medicine.
Yeah, towards what he saw as a rising tide of health fraud, dodgy cures, and pseudoscience. This led to him chairing a key committee in New South Wales back in 2002.
The Healthcare Complaints and Consumer Protection Advisory Committee. Quite a mouthful.
Informally known as the Quackwatch Committee, which tells you pretty much what its focus was.
Tightening the rules around wonder drugs and miracle cures.
Exactly. But what they found wasn't just a few bad apples. It was systemic. The regulations, the enforcement. They just weren't strong enough to protect people.
What were some of the specific problems they identified?
Well, first, the medical boards often lacked the teeth, the power, or maybe the will to really clamp down on practitioners promoting stuff that just didn't work.
Okay, what else?
Advertising was a huge one. Claims being made that had, as they put it, no basis in reality. And the voluntary codes of conduct that industries often rely on. Totally ineffective, basically useless.
So self-regulation wasn't working.
Not at all. Then there was the issue of training. Among alternative practitioners, there was often a complete lack of standardized training or advice. Consumers were left incredibly vulnerable without the basic protections you'd expect.
And the penalties for fraud.
Often trivial. Fines so small they were just the cost of doing business, not a real deterrent.
And what about the official government watchdog, the TGA, the Therapeutic Goods Administration?
They found the TGA was seriously under-resourced. It just didn't have the capacity to be the effective watchdog it needed to be, which, again, creates a low-risk environment for people selling dodgy products.
So the overall picture was pretty grim. Lack of power, poor advertising standards, inconsistent training, weak penalties, under-resourced regulator.
Yeah, a perfect storm, really. And their key recommendation was about coordination, getting all the different agencies, federal, state, consumer protection, health complaints, TGA, to actually work together. stop the fraudsters falling through the cracks between jurisdictions.
This concern about weak regulation then feeds into another big issue for him: public money.
Yes, he became very focused, almost relentless, on the issue of public funds effectively subsidizing unproven therapies, particularly through tax rebates for private health insurance extras.
Why was that such a big deal?
Because taxpayer money was going towards things that didn't work, and the scale of it was shocking. He highlighted data showing that between 2005 and 2015, the amount paid out by private insurers for natural therapies jumped by something like 345%.
Wow. So public policy was actually driving growth in this sector.
That was his argument. He was inadvertently propping it up. Homeopathy was the classic example.
Right. The NHMRC, the National Health and Medical Research Council, did that big review.
Yeah, a massive, comprehensive review of all the evidence worldwide. And the conclusion was unequivocal.
Yeah.
Homeopathy is no more effective than a placebo. There's just no reliable scientific evidence it works for any condition.
So Dwyer's response was?
Logical. If it doesn't work, why are we subsidizing it?
Yeah.
Stop the government financial support. Stop the private health insurance rebates for it. Public money should fund things that are proven to be effective.
Now, it's important to clarify here, he wasn't necessarily anti-all alternative or complementary therapies, was he?
No, not inherently. His position was nuanced. He advocated for integrating orthodox medicine with other approaches if, and only if, those other approaches had solid evidence behind them.
So evidence was the key criterion.
Always. He talked about wanting a converging pathway, taking the best evidence-based elements from different approaches, maybe mindfulness, specific exercises, certain nutritional advice backed by data, and incorporating them into unified treatment plans, not keeping them as separate, often conflicting systems.
Okay, so he's identified these deep systemic issues in policy, in regulation, in funding. It seems like the next logical step was to create a dedicated group to keep fighting for that evidence-based approach.
Exactly. In 2011, he was a key figure in founding Friends of Science and Medicine,
Right.
or FSM. He brought together this group of prominent Australian doctors, scientists, researchers. He was their first president, stayed in that role until 2019.
And their mission was pretty straightforward, wasn't it?
Crystal clear. Their mission statement says it all. To emphasize the importance of having healthcare in Australia based upon evidence, scientifically sound research, and established scientific knowledge. It's a direct defense of the scientific method in health.
And did FSM gain much traction?
Oh, absolutely. Within a few years, they had over 1,000 supporters. And these weren't just anyone. They included Nobel Prize winners, several Australians of the Year, really high-profile, credible figures. That gave them significant clout.
Where did they focus their efforts initially? What was the main battleground?
One of the biggest, and maybe most controversial, was academia, the universities themselves.
Why universities?
Dwyer and FSM were deeply concerned about universities offering courses in things like naturopathy, homeopathy, traditional Chinese medicine, and teaching them as if they were science-based health degrees, often under the banner of health science.
What was the problem with that in their view?
Several things. They argued it was a misuse of public funds, that it lowered the academic standards and reputation of the university, and critically, that it gave these practices a veneer of legitimacy they hadn't earned through evidence. It misled students and the public.
And this ties into the issue of professional registration too, right?
Yes, that was a crucial point. In Australia, many alternative practitioners are registered under the national scheme, AHPRA. That's the same body that registers your doctor, your dentist, your nurse.
So for the public, seeing that registration implies a certain standard?
Precisely. It gives an appearance of respectability, as Dwyer put it. But the catch is, for many of these alternative fields, the registration requirements are different. Because they're deemed low risk, the focus is more on basic safety standards, maybe insurance, rather than demanding rigorous proof that their core therapies actually work.
So registration without proven efficacy.
That was the concern. It grants credibility without necessarily guaranteeing effectiveness based on scientific evidence.
Did FSM get involved in specific university disputes over this?
Oh, yes. There was a well-publicized instance where they organized about 34 prominent Australians to write an open letter to Central Queensland University.
What was the issue there?
CQU was planning to expand its offerings in alternative medicine, presenting them as science. The letter argued this would diminish the academic reputation and give credibility to pseudoscience. It was a direct challenge.
So they weren't afraid to call out institutions directly. Did they also look at commercial interests?
Definitely. Dwyer was quite critical of the pharmaceutical industry itself, especially the big companies that also sell homeopathic products or nutritional supplements, alongside their evidence-based medicines.
Why criticize that? Business is business, right?
His point was about integrity and mixed messages. How can a company built on scientific research simultaneously profit from selling things that lack that same scientific basis? He suggested pretty bluntly that commercial reasons dominate those decisions, undermining their credibility.
And this connects to that case with Ken Harvey at La Trobe University.
Yes, that was another key moment FSM weighed in on. Ken Harvey, another strong advocate for evidence-based medicine, resigned from La Trobe.
Why did he resign?
He was protesting because a major vitamin company, Swiss, was funding a research center at the university specifically set up to study, well, Swiss's own products.
The potential for conflict of interest seems pretty obvious there.
Extremely. Dwyer and FSM publicly supported Harvey. They questioned why university resources were being used essentially to validate products for a commercial sponsor, potentially biasing the research outcomes, or at least the perception of them. It highlighted how these commercial pressures could compromise scientific integrity even within respected academic institutions.
Given this incredibly active and, let's face it, often controversial career spanning decades, it's no surprise he received significant formal recognition.
No, not at all. Back in 1991, he was made an Officer of the Order of Australia, the OA. That's a very high honor. The citation specifically mentioned his service to public health, particularly around infectious diseases, obviously reflecting the AIDS work.
And he holds the Emeritus Professor title at UNSW, and there's a lecture theatre named after him at the Prince of Wales Hospital.
Right. Plus his medical fellowships, FRACP in Australasia, and also a Fellow of the Royal College of Physicians of Ireland. Standard high-level professional recognition.
But there's another kind of recognition that perhaps captures the latter part of his career even better.
You mean the Skeptic Awards?
Exactly. Named Skeptic of the Year by the Australian Skeptics way back in 2000, and then won it again jointly in 2012 with the other founders of FSM.
Yeah, that really highlights his role as a public intellectual, fighting for critical thinking, for rationality, not just within medicine, but in the public sphere generally.
But as you said, when you take such a strong, often uncompromising stance, especially against things people believe in strongly or things that are commercially successful, you're going to attract criticism.
Oh, absolutely. Controversy is almost guaranteed. And while the criticism was often aimed at FSM as an organization, it definitely reflected the friction Dwyer himself generated.
Who were some of the critics? What were their arguments?
Well, Karen Phelps, for example, she's a former president of the Australian Medical Association and also someone who's been quite supportive of integrating complementary therapies. She described FSM pretty sharply.
What did she say?
She called FSM an ultra-conservative group with an alarming and far-reaching agenda. They actually debated publicly about what level of evidence should be required before universities teach something, or doctors recommend it.
So, a fundamental disagreement about the threshold for evidence.
Exactly. Phelps seemed concerned that FSM's strict insistence on things like large randomized controlled trials might unfairly dismiss therapies that patients find helpful, even if they don't fit that specific evidence model neatly. She sort of painted them as wanting to shut down anything outside a narrow definition of science.
Right, a clash of philosophies there. Was there pushback from the complementary medicine research community, too?
Yes. John Wardle, who's a prominent figure in complementary and integrative medicine research in Australia, had a pretty memorable description of FSM.
Which was?
He called them the new poster child for CAM, complementary and alternative medicine conspiracy theorists.
Wow, that's strong language. What does that imply?
It suggests that, from the perspective of some in the CAM field, FSM wasn't just advocating for evidence, but actively campaigning against them, perhaps unfairly, maybe driven by an inherent bias against anything non-orthodox. It frames FSM as antagonists, as obstacles.
So you have this real tension. FSM sees itself as defending scientific integrity, while some opponents see them as intolerant gatekeepers trying to delegitimize anything outside the mainstream.
That's pretty much the core conflict, isn't it? His entire later career really was spent navigating that difficult line, constantly pushing for verifiable evidence, whether it was popular, politically convenient, or commercially profitable or not. Hashtag tag outro.
So looking back at John Dwyer's career, it's this remarkable journey, isn't it? From the intricate world of cellular immunology, fighting HIV in the lab and clinic.
Yeah, where the science was literally life and death.
Right through to these huge system-level battles, fighting for structural reform in healthcare with HCRA, and then that very public fight against misinformation and pseudoscience with FSM. It's a lifelong commitment to evidence, played out on vastly different scales.
It really is.
Yeah.
And I think his career offers a kind of model, maybe, for how experts can engage publicly, using that deep scientific authority not just for research papers, but to provide moral and political leadership on really complex, messy issues.
Like managing pandemics or deciding how healthcare should be funded or what should be taught in universities?
Exactly. The common thread, the takeaway for you listening, has to be the absolute non-negotiable need for critical thinking in health. Whether you're facing a global virus or just trying to decide if a supplement claim stacks up, that rigorous questioning approach is vital.
And throughout our discussion, we've seen these recurring vulnerabilities in the system, haven't we?
We have. Financial pressures keep cropping up. Think about the insurance rebates potentially propping up unproven therapies, or corporate sponsorship maybe influencing research agendas at universities. Even our most trusted institutions aren't immune to these pressures.
Which leaves us with a really important question to ponder, doesn't it? We rely on experts like Dwyer, on regulators, on universities to maintain standards. But what's our role in this? What role do we as citizens, as health consumers, have in demanding transparency and demanding evidence?
That's the critical point. Where do we draw the line between respecting personal choice when it comes to health and upholding public safety or ensuring responsible use of public funds when those choices involve treatments lacking solid proof? It's a tough balance to strike.
Definitely something to think about. Thank you for joining us for this deep dive.